I'm going to get started. So Sam, I've got my colleague Sam Wharton on the call today. She's going to man the chat for me whilst I deliver the education. But if you've got any questions, please put them in the chat and Sam will answer them as we go through. Or if you want to wait till the end and you're happy to come off microphone and have a chat to us, then that'd be brilliant. But can you see my slides, Sam?
Yeah, we can see them. Thanks, Charlie.
Perfect. So welcome to today's webinar with Coloplast. It's around making life easier, utilising the three-step approach for leg ulcers. My name's Charlie Lay and I'm one of the tissue viability nurse specialists for Coloplast. I've been with the company for about 2.5 years now, but I have been a qualified nurse for 16 years. Which is starting to make me feel old when I say that out loud now. I have a varied background, so I've worked in the acute, I've worked in the community, I've worked as a general practice nurse and also more latterly as a tissue viability nurse specialist within the acute. I came over to this job in Coloplast or in industry because I feel that there is a real gap in the market around wound care education. You get very little when you are doing your training, your nurse training, and then once you qualify, you may get a yearly update on pressure ulcers, but otherwise it's quite few and far between the wound care education that is given. So my job really is to support tissue viability nurses throughout the country to help them deliver on their education and also help with service improvement and service development. So that's a little bit about me. So I'm going to stop talking about myself now and I am going to take you through today's webinar. Like I said, please, if you've got any questions, pop them in the chat. You will get sent a recording of this. We won't send the slides, but we will send a recording and you will get a certificate sent to you as well. So if there's anybody that hasn't registered that sat with you, please make sure that they do register. Okay, so during today's session, I'm going to introduce you to the three-step approach of assess, prepare and treat, which is an easy step-by-step framework to help you and your patients on their wound healing journey. We're going to talk about a simplified approach to wound healing, understand the impact and cost of leg ulcers in the UK, because we are spending an awful lot of money on wounds in general, but also on leg ulcers. We'll have a look at the guidance from the leg ulcer recommendations from the National Wound Care Strategy Programme, and then you will leave with the three-step approach leg ulcer pathway to support your practice. So it is well recognised that ulcers as a result of underlying venous disease are the most common etiology of leg ulceration. Now, Guest and others did a study in 2012-13, and then they repeated that again in 2017-18, looking at the burden of wounds on the National Health Service. Now, that study found that there were at least 730,000 patients with leg ulcers in the UK. Now, I say at least because they are the diagnosed ones. I'm sure that number could probably double with the amount of leg ulcers that are undiagnosed. But that number, the 730,000, equates to about 1.5% of our adult population. So that's quite a lot of people that have got a diagnosed leg ulcer. Now, it's estimated to have increased by 101% between the year 2012-13 and 2017-18, and that is just for venous leg ulcers. Now, the number of diagnosed venous leg ulcers indicates that 1 in 170 adults have a venous leg ulcer, and I would say that that number is actually lower than 170 because, as I've said, there's an awful lot of leg ulcers out there that haven't been diagnosed. As I said at the beginning, there is a huge cost burden to wounds in general, but also to leg ulcers. Now, leg ulcers not only cause that loss of function, but they require long-term care, and that results in a high financial burden. But it also impacts that patient. It means that that patient's quality of life is affected, how they carry out their activities of daily living is affected. It can affect their mental health. It can cause isolation. And so it continues. There's an awful lot to think about. But with the considerable variation in practice, the increase in care costs and extending healing times keep getting more and more and more. So we're looking at around £1.94 billion that we are spending looking after leg ulcers. The average of around just over £7,500 per patient with a venous leg ulcer, and that can then increase to about 13,500 for an unhealed venous leg ulcer. And of course, this is taken from guesswork, which was quite some time ago now. So those costs that you can see on this screen are likely to have increased by quite considerably. So this is the three-step approach of assess, prepare and treat. And as I said, it's a nice, simple, easy framework to help you heal your patient's wounds or help you to get your patients onto that positive healing trajectory. So step one is around assessment, and that is around doing a full holistic assessment of your patient, really understanding what is going on with your patient, understanding what their comorbidities are, understanding the cause of that wound in the first place. Is it one of their underlying comorbidities that has caused that wound? So have they got a venous insufficiency that has caused that, that venous leg ulcer? Is it to do with their diabetes? And is that diabetes being well managed? Are they taking their medications? Is their diet appropriate? Are they able to mobilize? So there's lots of things to consider when you're looking at doing your holistic assessment, but it's really important that we get a good rounded picture of that patient before we then move on to the wound itself. So whole patient first before whole in your patient. When you're looking at your patient's wound and you're doing your wound assessment, it's really important that you look at all three aspects of that wound. So your wound bed, your wound edge, and your peri-wound skin, because each is just as important as the other. If you look after your wound bed really well, but neglect your wound edge and your peri-wound skin, the likelihood of that wound healing is very, very low. So we have to look after all three aspects. Once you've done a really robust assessment of your patient and of their wound, you move to step two, which is preparation. Now, wound preparation is key to removing those barriers to healing, and it helps us create that optimum healing environment. Wound preparation helps us to remove devitalized tissue, debris, and reduce the bioburden that is in those wounds. It helps create that moist healing environment that we know we need for that wound healing to progress. Once you've done step two, you'll move to step three, and this is around a simplified portfolio of dressings that are available to you on your formularies that will help you to manage a wound of any depth and any stage of healing. So your assessment and the aims of your wound assessment is to, as I've already said, identify that cause of skin breakdown. If you can identify what has caused that, and we can ensure that we are managing that appropriately, we're more likely to heal that wound. We need to identify any of the associated risk factors. So as I said, if your patient is diabetic, are they taking their medications properly? Are they taking enough insulin? Are they checking their blood sugars if they're meant to do so? If they're not taking their medications, why aren't they taking their medications? Are they managing their diet appropriately, or is their diet too high in sugar? So there are lots of things that we can look at to help that patient to ensure that we make wound healing as easy as possible for that person. We need to identify the appropriate management options. We need to prevent any further skin and wound breakdown and deterioration. But we also know we need to provide psychosocial support and promote patients' independence. So where possible, get your patients involved with the care that they are having. Make sure that you talk to them about supported self-management and them being involved in actually delivering their care. So we know that wound assessment can be complex, with reasons for this being multifactorial. But by using a simplified wound assessment framework, such as the triangle of wound assessment, that can really help simplify that process for you. So your frequency of wound assessment will very much depend on the condition of the patient, the condition of the wound, and the care setting. But also, it will also depend on you. as the healthcare professional. It's your clinical assessment, your clinical judgment, but we would recommend that a holistic wound assessment should be, as a minimum, every 2 weeks in the acute setting and every 4 weeks within a primary care and community setting. Now, we say every 2 weeks in the acute setting because patients are generally acutely unwell when they are in the acute setting. So things can change quite quickly with them. Their condition can improve quite quickly, but it can also deteriorate. So I would also suggest that if your patient's condition has changed, we should be looking at doing another holistic wound assessment. Now, this is the triangle of wound assessment. For those of you that haven't seen this before, you may start to notice that we like things in threes at Coloplast. We have the three-step approach of assess, prepare and treat, and then the triangle of wound assessment, looking at your wound bed, your wound edge and your peri-wound skin. What I like about this is the circle around the patient, because that encompasses your whole patient before you look at the hole in your patient. Okay, so it's really important to do that full holistic assessment of your whole patient. Think about any socio-economic factors. Think about whether that patient is working, if they've got young children that they need to care for, before you then think about looking at the wound. And when you do look at that wound, always look at the wound bed, the wound edge, and that peri-wound skin. Now, these are some of the indicators of underlying venous disease, and I'm not going to read them all out to you, but I will pick a couple out. So, significant past medical history of a DVT, deep vein thrombosis, any pulmonary embolisms, lower limb fractures, family history of venous disease, and varicose veins. So, all you ladies that have had babies or have spent long periods of time nursing patients in the acute setting and you're on your feet for long periods of time, worked in theatres, anything like that, the likelihood is you may have some varicose veins. I know I certainly do. Indicators of that venous disease, so ankle flare, and you can see that on the picture here, these tiny little thread veins at the bottom, so that is your ankle flare. Your varicose veins, which we've talked about. Your lipodermatosclerosis, so that's the hardening and discoloration of those lower limbs. Edema, so swelling of that lower limb. Any eczema or dry skin, and then your atrophy blanche and your pain and heavy feeling in those legs. Now, the risk factors, medical conditions that you need to think about: hypertension, chronic edema, hormonal changes, and then arteriovenous fistulas. Now, lifestyle, obesity, physical inactivity, stress, history of IV drug use, occupation and hobbies, and then multiple pregnancies. But also look for signs of lymphedema as part of your clinical assessment. So these are your indicators of underlying arterial disease. So the patient may have a significant past medical history of cardiovascular problems, stroke, MI, so myocardial infarction or angina. Some of the indications of arterial disease, probably the one that everybody knows, is around that intermittent claudication. So it's that pain on walking, and the patient will be able to tell you literally, I can do 30 steps before I get this cramping in the back of my calves. They will know how far they can walk. Cold extremities, discoloration in the toes, absent foot pulses, deep and punched out ulcers, and ulcers are more common on the lateral ankle, malleolus, or the dorsum of the foot. Now, the risk factors are very similar: hypertension, diabetes, rheumatoid arthritis, hyperlipidemia, and hormonal changes. Lifestyle, again, smoking, high cholesterol, obesity, physical inactivity, and stress. Now, when you're looking at doing your wound assessment, you break it down into your wound bed, your wound edge, and your peri-wound skin. So when you're looking at your wound bed, you need to look at what tissue type you have in that wound bed. Is it necrotic? So is it black or dark brown? Is it hard or soft? Is it sloughy? So that yellowy, it can be yellowy white, yellowy green, yellowy grey sometimes, and can look quite fibrous at times, tissue. Granulation tissue, so healthy granulation is pinky red in colour. It shouldn't be dark red. It shouldn't bleed easily. And then you've got your epithelialization. So that is the the epithelial cells that migrate across that wound bed to close. They usually start from the wound edges. You may get little islands of them, and that's often around the hair, where the hair follicles were. You need to think about your exudate. So is that wound dry? Is the exudate low, medium, or high? Please try and describe the exudate that you can see. So what is the thickness like? So is it thin and watery, or is it thick and purulent like pus? What colour is that exudate? Is it clear? Is it cloudy? Is it pink or red? Is it bleeding? You need to think about signs of infection. So your local signs of infection: increased pain, redness, edema, warmth, increased exudate, delayed healing, friable granulation tissue, so that granulation tissue that bleeds really easily, malodor, smell, or pocketing. Or if it's a spread in a systemic infection, there will be increased erythema, so that erythema will start to spread up that limb. The patient's likely to have a temperature. There could be an abscess or pus formation, wound breakdown, cellulitis, general malaise, so the patient's just feeling generally unwell. They could have a raised white blood cell count and lymphangitis. With your wound edge, you need to look at whether that wound edge is macerated, so that you can see that in this first picture here. So you can see that white tissue. It's basically waterlogged tissue. And that's likely to be because the exudate isn't been managed appropriately with the dressings that are being used. Is it dehydrated, like this picture? So that wound bed and that wound edge is really dry. That wound won't heal like that. We know that we need to have a moist wound healing environment. Is the edges undermining? If they are undermining, it's likely that there's chronicity to this wound. It's a chronic wound, and quite often you will be able to probe either your finger or a wound probe underneath there quite a lot. And then there are your rolled edges. Again, this rolled edges suggest that this wound has been here for a while. Rolled edges can be removed via surgery to allow that wound edge to heal. So they cut away that rolled edge to allow it to be a normal edge again, to allow that wound to heal. But it can also be a sign of cancers and things like that. So, you know, if you suspect that there's a problem, make sure that you do your referrals. And then you look at your peri-wound skin assessment. So when you're looking at your peri-wound skin, you're looking to see if there's any maceration. So again, this is because the exudate isn't being managed appropriately by the dressings. And as you can see, this exudate is pooling all around the bottom of this heel. With legs and gravity, the exudate is going to come towards the bottom of that wound, which is why you need a dressing that's going to manage that appropriately. Is there excoriation or dry skin? And if they've got dry skin, what are we doing about it? Because the patient can get stuck in that itch scratch cycle. They have an itch, they scratch it, they cause trauma. This opens up the skin, allows bacteria in, and so on and so forth. Is the surrounding skin full of hyperkeratosis? Is there a callus, which you often find with diabetic foot ulcers? Or does the patient suffer with eczema, particularly on that lower limb? Now, there are further investigations that you can do to help with diagnosis. So you can do a blood screen of an FBC, UNE, RBS, ESR, and CRP for your non-healing wounds, and that will help determine if the patient is suffering with any anemia, any hyperglycemia, or systemic infections. You can do wound swabs for non-healing wounds that have failed to progress or deteriorated with current antimicrobials. Now, this will only give you the pathogen that is causing the infection along with the relevant sensitive antibiotics. But we know that 80 to 100% of non-healing wounds will contain bacteria. So that wound swab is always going to come back with something on it. You can do an ABPI, so your ankle brachial pressure index for your patients that you suspect have a leg ulcer. So you would do that in line with your full lower limb assessment, and that will determine the arterial perfusion to that lower limb. But you can also do the pressure perception, so for patients that have got diabetic foot ulceration, and that will help with sensory neuropathy. Now, the National Wound Care Strategy Programme did release some leg ulcer recommendations in August of 2023, and this was for immediate and necessary care. Now, the red flags for your immediate and necessary care are acute infection, your symptoms of sepsis, acute or suspected chronic limb-threatening ischemia, DVT, suspected skin cancers and bleeding varicose veins. Now, the immediate and necessary care is that you can apply 20 millimeters of mercury to patients that you suspect have got a leg ulcer on that lower limb. You can apply the 20 millimeters of mercury until you do that full lower limb assessment and the ABPI. However, if your patient has any of these red flags, then it's best not to apply that compression until you have done that full assessment. And if the patient has got an infection, then perhaps when that infection has subsided or any of the other things that you are suspecting as red flags have been ruled out. So you need to, or we should be, arranging for a full lower limb assessment and that ABPI within 14 days of first seeing that patient. So you need to treat that wound for any infection, clean the wound and the surrounding skin and apply an emollient. And the emollient will help if they've got dry skin. It'll help get that surrounding skin in better condition and can help break that itch scratch cycle. Record a picture of the patient's wound. Use a simple low adherent dressing with sufficient absorbency. For those patients that don't have any red flags, you can offer mild graduated compression, so that up to the 20 millimeters of mercury, and then signpost your patients to the relevant high quality information. So if you've got any information leaflets, or you can direct them to different websites and things like that. If the patient has got suspected venous disease with an adequate arterial supply, you need to refer these patients to the vascular services for diagnosis and intervention and apply strong compression therapy. If the patient has got suspected venous disease and peripheral arterial disease and their ABPI is below 0.5, then they need an urgent referral to the vascular team. If their ABPI is above 0.5, then you can refer them to vascular services. So below 0.5, they need an urgent referral. Above 0.5, they just need to be referred. Other uncertain etiologies, so you're not sure if it's a venous disease or an arterial disease, then refer to the appropriate service. If their ABPI is above 0.8, then you can consider the use of strong compression. And for patients that have lymphedema, the care should be delivered by clinicians with capabilities to manage that lymphedema. Some areas are lucky enough to have a lymphedema service, but I know other areas, the lymphedema patients are very much managed by the community teams. So your ABPI, your ankle brachial pressure index, provides an index of the vessel competency by measuring the ratio of the systolic blood pressure at the ankle and at the arm. So for those of you that have never done an ABPI or seen one done, it's very much like taking a blood pressure, but you use a little Doppler as well to listen to the sounds of the blood pressure when the heart rate that you can hear. The ABPI values should always be interpreted in context of signs and symptoms. So you shouldn't just go on the value alone of that ABPI. You need to also think about the signs and symptoms that your patient is displaying. So if they have an ABPI of less than 0.5, that suggests that your patient has got severe arterial disease. Compression treatment is contraindicated and they must be referred urgently for vascular assessment. If they have an ABPI between 0.8 and 1.3, that suggests that there's no evidence of significant arterial disease. So compression may be applied safely for most people. And remember, think about your red flags as well. If their ABPI is greater than 1.3, that suggests that there's arterial calcification. So compression may be used, but with caution, and they should still be referred for a vascular assessment. If you get patients that have an ABPI that is greater than 0.5 but less than 0.8, that suggests the presence of arterial disease or mixed arterial and venous disease. So compression should be avoided, but reduced compression could be used under specialist advice, and they need to be referred for a vascular assessment. So if you get an ABPI reading that you're unsure of what to do with for your patient, whether they can go into compression or they can't, then do escalate that. Speak to your seniors, speak to your tissue viability team if you're covered by a tissue viability team. If you know that that patient is under the care of the vascular team, then do give them a phone call and work with your MDT to find out what the best course of treatment for that patient is. Of course, like everything that we do with our patients, we should be communicating with them and communicating effectively, but you need to confirm your action plan with the patient. So what are you going to do and why are you going to do it? If your patient understands what you're doing and why you're doing it, they're more likely to comply with the treatment. You need to let them know if they need to have any special investigations or if they're going to be referred onto another team and why. If you can detail the specific treatment that they are having, brilliant, talk them through that. Find out if they are able to support in their own care. So think about supported self-management, and then think about your plans for discharge if that is appropriate. Okay. So we've done step 1, your assessment for your lower limb. And we've made sure that we've talked about what a holistic assessment is, and then we have gone through your wound assessment of your wound bed, your wound edge, and that peri-wound skin. So your second step is step 2, preparation. So as clinicians, these are some of the challenges that you may face out in clinical practice, and I know there's certainly challenges that I faced in clinical practice. So your wounds that have are obscured with slough, which you can see in this first picture. Wounds that have necrotic tissue. Now this necrotic tissue here has already started that autolytic debridement. It's soft and it's starting to come away, but that necrotic tissue could also be hard and quite black in colour. There's likely to be a bioburden with this wound. You can see the erythema around that wound is starting to spread further than just the margins of that wound edge. And then you've got your hyperkeratosis, which I'm sure you've all seen before. This is something that I used to love having a good pick at in my community days. But we know now, don't we, that we have got tools on our formulary that can help us with hyperkeratosis and removing some of these challenges that we face in practice. Now, 80 to 100% of non-healing wounds do contain a biofilm, and a biofilm is a structured community of microorganisms with that genetic diversity that creates chronic infection. And they are significantly tolerant to antibiotics and antimicrobials, but remain protected from the host defense. Now, the easiest way for me to explain to you what a biofilm is if you imagine an army of soldiers that are in a rectangular formation. Now, these are soldiers from way back when they used to have a shield. So in that rectangular formation, the soldiers that are all on the outside of that formation hold their shields up against their bodies, so that protects them all the way around outside. Those that are in the middle will hold them above their heads. So that means they are protected all the way around the sides and over the top. That is what a biofilm is. It has this added layer of protection. So what we need to do with a biofilm is to prepare that wound. So using something like an all-prep pad or whatever is available to you on your formulary, by the mechanical debridement, it knocks off some of those shields and allows you to get down to some of that bacteria, removing some of that bacteria. And then the treatment that you then use will penetrate that bacteria and stop it from multiplying. Now, biofilms aren't visible to the eye, but signs of infection do indicate the presence of biofilm. So the wound will be delayed. It won't be healing as you would expect it to. It might be static, it might be deteriorating, but it's not doing what you would expect. You can get increased exudate and slough with that wound, an increase in that inflammatory response. So that's likely to come with the increased exudate. We know that biofilms can cause wounds to get stuck in that increased inflammatory response. So we need to break that cycle to move that wound on to healing. Erythema, so that redness, malodor, the smell, and a high bacterial load. So there is best practice, international best practice, for the management of biofilms and infection, and that does come from the International Wound Infection Institute. So the first step is around wound preparation, so that will help with cleansing and debriding to reduce the number of microorganisms by disturbing and removing some of the biofilms, but it'll also help reduce and remove devitalized tissue and debris that's also in that wound too. Step 2 is around applying a barrier dressing. So you need a dressing that conforms down into the wound bed, absorbs vertically, and then traps that exudate away so it can't recontaminate that wound bed. And step 3 is around your infection management. So this is around suppressing that biofilm formation, reducing the existing biofilms with an active agent in the dressing. So something like a silver. So by cleansing and wound debridement, we remove those barriers to healing, such as slough, non-viable tissue and biofilms. Now, as you can see, everything disappeared from inside this wound. We know that with our chronic wounds, our venous leg ulcers, our arterial ulcers, they are going to heal by secondary intention. So what we need to do is make sure that we have the healthiest wound bed that we can. We want granulation tissue in this wound bed because your granulation tissue is your building blocks. That starts to build up in this wound until it gets almost level with the skin, and then your epithelial cells will start to migrate across that wound bed and allow that wound to heal. So it is clinically proven that cleansing and debridement speeds up that wound healing process. Now, what you can see on this slide comes from a study done by Wilcox and others back in 2013. So this is not new evidence. It's, 12 years old now. Now, this was looking at the frequency of debridement and the time to heal. It was a retrospective cohort study that was done of around 310,000 wounds. What you can see here on the screen is this is just looking at diabetic foot ulcers, and that was around 50 to 60,000 wounds. But what they found was if you debrided or prepared a wound once every 2 weeks, the average time for healing was 76 days. However, if you prepared that wound then and increased it to once a week, the average time to healing for that wound was 21 days. Now, I don't know about you, but if that was my wound, I know that I would far rather only have my wound for 21 days than more than 3 times longer than 76 days. So I would recommend, but obviously you must follow your local policies and procedures, that each time you change that patient's dressing, we should be preparing that wound. We should be cleansing and debriding to ensure that we are removing and reducing the biofilms, removing and reducing the devitalized tissue, and removing any debris that may be sat in there. So your holistic assessment directs wound preparation. So that your wound preparation is more of a holistic approach. Your debridement is the task, but is incorporated in wound preparation. So wound preparation is about that cleansing and debridement. It's more of a holistic approach. So washing and cleansing of wounds does not require any extended competencies and training. Then you have your autolytic debridement. Now, autolytic debridement is the body's attempt to shed the devitalized tissue by the use of moisture. So by us, the healthcare professional, applying a dressing to that patient's wound, what we are trying to do is to help speed up the body's own attempt to shed that devitalized tissue, because that dressing will help aid that moist wound healing environment. Mechanical debridement, so use of your mechanical debridement pads that you have available now, such as the All Prep pad that we do at Coloplast. Biological debridement, so this is around your maggot therapy, your larvae therapy. It's sterile maggots, not the homegrown kind that I'm sure lots of you have seen in the past. And then you've got your enzymatic debridement. So this is an ointment or gel that contains enzymes that soften and lift that necrotic tissue. Now, none of those need extended competencies and training, but that does require some knowledge and skill to be able to undertake them. And then you've got your conservative sharp debridement, or surgical debridement. So this is the use of your scalpel, your forceps, your curette, or your scissors to remove that devitalized tissue, which may require a local or general anesthetic if you are doing sharp or surgical debridement, but shouldn't if you are doing conservative sharp debridement. Now, this is an extended skill. You have to go on a course to be able to learn how to do this safely. Then you have extended competencies to complete. So please don't all start yielding a knife or a pair of scissors and cutting away at the devitalized tissue in your patient's wound. You must have the extended skills and competencies to be able to do this. And it's likely that your tissue viability team will be able to carry out conservative sharp debridement. Potentially, sometimes some district nurses may have been on the training and some practice nurses may have been on the training, but don't take it for granted that everyone can do this, because they can't. So the National Wound Care Strategy does recommend the wound, the wound and the surrounding skin are cleansed and debridement is considered if required. And as you can see here, this is our all prep pad. You can see that there is a lighter grey side and a darker grey side. The darker grey side is for helping to lift that devitalized tissue. It's to loosen, basically. It's a little bit rougher in texture. And your lighter grey side, as you can see, there's lots of little squares. Well, actually what they are is unique slits, and they will collect anything that you have loosened in that wound. If there's any exudate, it'll help soak that up. So that is your all prep pad there. How often wound preparation is required is very much up to you as the clinician. It's down to your assessment and your clinical judgment. It's around what your treatment goals are for that patient, but it also needs to be around the patient's pain. Some patients' wounds are extremely painful, and you only have to look at them and they say, "Oh, don't touch my leg," because it's so painful for them. With wound preparation, it might be that you have to start at only maybe 20 seconds, 30 seconds of doing a bit of wound preparation, and then building that up each time you see your patient. Now, ideally, wound preparation with all prep pads should be done for 2 to 4 minutes. However, 30 seconds of wound preparation is better than nothing at all. So if that is all your patient can tolerate, then I would take the 30 seconds. The other thing to think about is, if the patient is in pain, is to give them the wound preparation tool and ask them to prepare their wound. They will be able to tolerate far more if they're doing it to themselves than if someone is doing it to them. And the analogy that I always use is around a spot, like on your face or on your back. If you squeeze your spot, it's far less painful than if your partner or your daughter or whoever it is squeezing that spot for you, because you can tolerate far more when you're doing it to yourself. There are course times that we need to be cautious with wound preparation. So if a patient has a wound on the lower limb and is known to be diabetic, that may be suitable, but it may require specialist advice. Now, if your patient does have a limb on the lower limb, hopefully they've got a limb. If they have a wound on that lower limb and are diabetic, if it's on the foot particularly, then lots of trusts now have access to podiatry for patients with diabetic foot ulcers. So if you are sharing the care with the podiatrist, please do follow the care plans that the podiatrist put in place. If you don't have access to podiatry, please do speak with your tissue viability teams if you are covered by tissue viability. If a patient has a known arterial flow concern or poor localized tissue perfusion, then the likelihood is that these patients are going to be under the care of the vascular team. The vascular team may already have put a care plan in place, but if they haven't, think about what it is that why are you going to prepare that wound? What is it that you're trying to do? What is it going to do for the patient, and what is it going to do for that wound? So think about your assessment of your patient. If that wound has got a poor localized tissue perfusion, we know that the blood and the nutrients aren't getting to that area, so that wound is not going to heal. Now, if that area with the poor localized tissue perfusion has a dry scab on it, it might be that actually it's best for us to leave the dry scab there. I know that goes against everything with moist wound healing. However, if we're not getting a blood supply there, we're not getting the nutrients that are going to help with that wound healing, all we are doing is open that patient up to infection because that wound isn't going to heal. So it's about assessing your patient holistically and their wound, and about being part of that MDT and having those discussions. We don't all know everything, and it's absolutely fine to ask somebody, what should I be doing here? If the healing ability is impaired because of medications or underlying medical conditions, so think about perhaps your patients that may be going to start chemotherapy, they may already be on chemotherapy, or they're immunosuppressed. It might be that they need to have this wound healed before they can start their chemotherapy. But if the patient is already on cytotoxic medications, it might be that they want to wait until they have finished the cytotoxic medications, or the specialists might, before you carry out wound preparation, and the same with immunosuppression. So again, it's around those discussions with the MDT. So we have done a full holistic assessment of our patient, and we have utilised the triangle of wound assessment to assess our wound bed, our wound edge, and the peri-wound skin. We have done wound preparation to remove those barriers to healing, remove the devitalised tissue, the debris, and reduce the bioburden in that wound. So now we're going to move on to step 3, which is your treatment. So your treatment, you will identify at your assessment your treatment objectives, and also through your wound preparation. So our aim is always to provide that optimum healing environment for that wound. So you need to think about what your treatment objectives are. So is it around management of exudate or exudate pooling? So do we have the appropriate dressing that can manage that exudate to prevent pooling in that wound? So does it conform down into that wound bed? Does it absorb that exudate vertically, and does it lock it away to prevent any of that maceration on the surrounding skin and that wound edge? Is there any infection that we need to manage there? Do we need to be using antimicrobial dressings? If that infection is now a spreading or systemic infection, are we ensuring that the patient is following the right plan of care to make sure that that infection starts reducing? Now, there are lots of dressings available on the market, and it is really quite essential that you do know what each of your dressings does that's available to you on your formulary. But commonly used dressings can be broken down into categories. So you have got your foams, you've got your antimicrobials. So this is your silvers, your honeys, your PHMBs, your hydrocolloids, your contact layers, your gelling fibers and alginates, your films, your odor absorbers, and your hydrogels. So again, it's very much around that assessment of that patient and their wound, and what your treatment objectives are going to be as to what dressing you will be using. Now, the National Wound Care Strategy Programme does recommend the application of a simple, low adhering dressing with sufficient absorbency. And what you can see here in this picture with this wound is the biotain silicone. And biotain silicone has 3D fit technology. As you can see on this dressing, it kind of bubbles. So what it does is it conforms down to that wound bed, it absorbs vertically, and it locks away the exudate and the bacteria to prevent that from being re-added back into that wound. Now, strong compression therapy for suspected venous disease with an adequate arterial supply. So think about your hosiery kits. So they're a type of medical compression, most commonly used for the management and healing of venous leg ulceration. It consists of 2 medical compression garments that are designed to be worn one on top of the other. Most kits contain 2 liners and a stocking. It's designed to deliver 40 millimeters of mercury of pressure at the ankle, reducing to 20 millimeters of mercury at the calf. Now, the recommendation is to be worn for 24 hours, but the outer layer may be removed at night. Now, do remember, these are your patient's legs, They very much do have a choice in the care that they get. They might agree to wear their compression 9 till 5 and then tell you, I am taking it all off at night time. That is their choice to do that. It may be against the advice that we are giving. You may feel that it is an unwise decision, but it is the patient's choice. So you just need to document that is what has been discussed, that is what the patient has decided, but also continue to have those conversations with the patients and ensure that they do fully understand that if they haven't got their compression on, it's not doing what we need it to help heal that wound. So your hosiery kits are available off the shelf, but can also be made to measure as well. And they come in all different colours. You can have ones that have got toes or without toes. You can get ones that look like socks for men. You can get tights and like thigh-high stockings for women. So there's lots of different things available on the market. So we're just going to talk about how we can make your life a little bit easier. And these are just some case studies that we have done. So this is a gentleman that is 90 years old, and he had no other comorbidities. He had a mixed etiology leg ulcer that was present for more than 10 years. His ABPI was outside of normal parameters, so wasn't suitable for full compression. And all this gentleman wanted to do was go on holiday and get in the sea, but he hadn't felt confident to travel since he'd had that wound. So he hadn't been for 10 years. Now his assessment and the management goals were to remove the non-viable tissue in that wound, manage the exudate, manage the bacterial burden, because remember, this patient has had this wound for 10 years, definitely going to have a biofilm in there. Protect the granulation and epithelial tissue and protect the surrounding skin. Now, this gentleman's wound was prepared with all prep pad, and he was then treated with biotin AG non-adhesive. He was able to tolerate 10 millimeters of mercury compression, so he had a liner after day 3, which he couldn't have done before due to the pain and the exudate levels. So after managing the infection and the exudate levels with the biotin AG non-adhesive and the 10 millimeters of compression, he was then able to share his care by using the biotin silicone and hosiery and his hosiery. Now, after 54 days of treatment, this wound healed. And I'm glad to say that despite being 90 years old, this gentleman did get to go on holiday and did get back in the sea. And ultimately, that's what we want, isn't it? It's about giving our patients the best quality of life. And for him to have the best quality of life meant going on holiday and getting in the sea, and he was able to do that. So in clinical practice, we have done a 60 patient evaluation so far, and this has been published. We are looking at doing 200 patients evaluation, which we're well on our way to. But from the 60 patient evaluation that has already been published, 4 of our patients were identified to have a simple leg ulcer, and 32 patients were identified to have complex leg ulcers. Now, a complex leg ulcer was defined as having one or more of the following. So a wound surface area of 10 by 10, 6 months duration, not improved or reduced by 40% within 4 weeks, abnormal ABPI, so outside that 0.8 to 1.3 or unable to gain a reading, current infection or history of infections, history of non-concurrence, an active ulcer with one measurement between 2 to 6 centimeters, and then comorbidities that include peripheral arterial disease, diabetes, sickle cell anemia, self-harm, IV drug use, rheumatoid arthritis, immunocompromised, and mobility restrictions. Now, the overall results for the leg ulcers were that the average duration at baseline assessment was 73.2 weeks. Okay. Following implementation of the 3-step approach of assess, prepare with all prep pad, and treat with 3D Fit technology, the average healing time was reduced right down to 6.5 weeks. So of the 43 leg ulcer patients from the initial 60, 34 of those have healed. That was 79% of those patients had healed, and actually more have gone on to heal. Obviously longer than the 6.5 weeks, but the average was 6.5. And none of these patients received any antibiotics during that evaluation period. Now, the simple leg ulcer results, so this was the four patients that had a simple leg ulcer. The average wound duration at baseline assessment was 8.75 weeks. Following the implementation of assess, prepare with or prep pad and treat with the 3D Fit technology, the average healing time was 3 weeks, and all of those patients healed with none of them receiving any antibiotics during that evaluation period. With the complex leg ulcer results, so this is 32 patients, the average wound duration was 39.23 weeks. Then we implemented assess, prepare and treat, and the average healing time following the implementation of assess, prepare and treat was 6.3 weeks. 91% of those patients had healed and none of them received any antibiotics during the evaluation period. So we have gone through step 1 assessment, full holistic assessment of your patient and of their wound. Step 2 around preparation and removing those barriers to healing, creating that optimum healing environment using All Prep Pad. And step 3 around your treatment of simplified portfolio of dressings utilizing 3D Fit technology to manage a wound of any depth and stage of healing. Now, this is the venous leg ulcer pathway that we have here at Coloplast, and it's a nice, easy to follow pathway if you don't have a pathway already in practice. So does the patient have signs of arterial insufficiency? If they do, you follow the yes arrow and you dress that wound as per the local guidelines and refer to a specialist as appropriate. If the patient doesn't have signs of arterial insufficiency, have you completed an ABPI? Yes. Is that ABPI 0.8 to 1.3? Yes. Then you need to prepare that wound for healing using your All Prep Pad and consider what your treatment objectives are. Refer to your product selection guide, apply the 40 millimeters of mercury compression and review your frequency as per your local policies and guidelines. If you haven't completed that ABPI, you need to prepare the wound for healing. You need to refer to your dressing selection guide. You can apply the reduced compression of 20 millimeters of mercury, and then you need to plan and complete your ABPI. If the ABPI isn't between 0.8 and 1.3, you need to think about whether that wound is improving. If it is, then continue the current management and refer to the specialist as per local guidelines. If that wound is not improving as you would expect, then you would review your holistic assessment to optimize the factors that are delaying that wound healing, prepare the wound for healing, and refer to the product selection guide and your local compression guidelines, and perhaps refer to the specialist as per your local guidelines. And then you will do your reassessment and continue. This is your product choice with the Coloplast products. So step 1 is around assessing the wound using the venous leg ulcer pathway. Your step 2 is around your preparation, and your step 3 is around your treatment. So your dressings, if there's no infection present and that patient is able to go into compression hosiery or leg wraps, you could use biotin silicone or biotin silicone light. If they're going into compression bandaging with no infection present, they could use biotin silicone or non-border or biotin non-adhesive. If there is infection present, then we do have biotin silicone AG, and we have biotin AG non-adhesive to go under compression bandaging. And if the patient is experiencing pain, then there is biotin iBu that is available. So for any additional support on our products and services, we are able to offer you a follow-up telephone call from our specialist team to discuss any face-to-face or virtual education that you feel that you or your teams may benefit from. So please do scan this QR code, or we will try and put a link in the chat for you as well. And one of our dedicated team will give you a call after the event takes place. We do also do a podcast, so Wound Care Conversations. I think we've got about 8 podcasts out now that talk about various different aspects of wound related conversations. We do talk about assess, prepare and treat of different etiologies, but we also talk about supported self-management, our love of tissue viability, fact and fiction. So please do give it a listen if you are interested in wound care. It is available on all of your sort of podcasting platforms, Apple, Spotify, Google, Amazon, and all of those. And that is the end of today's session. So I'm just going to stop sharing and ask Sam if there's any questions in the chat that we need to go over, or if anyone wants to come on and ask a question, then that would be brilliant.
Well done, Charlie. Brilliant. Great presentation. You're getting lots of thank yous. There were no specific questions in the chat. Lots of people asking about getting resources after today's session. So everyone will receive a recording of the session. And just you'll see, Charlie, lots and lots of thank you. So really, really good session. Well done.
Brilliant. Thank you. And thank you all for joining us today, taking time out of work or even out of your own time. We really do appreciate it. I'm going to give you 5 minutes back, so go and get a quick cup of tea before you have to go back to work if you are working, but make sure you use that 5 minutes wisely, and I hope that you will join us again soon. Thank you very much.